Hello, my name is Laura Berry, family nurse practitioner student at East Tennessee State University. This presentation will discuss the geriatric syndrome of falls. A fall is defined as a sudden, unintentional change in position that causes a person to move quickly downwards onto or towards the ground. Falls are the leading cause of fatal and non-fatal injuries among older adults in America. Contrary to widespread belief, falling is not a normal part of the aging process. As providers, we need to educate our older adult population that falling is often an indication of other underlying health problems. The risk of falling can be reduced by identifying those causes and making lifestyle modifications based on evidence-based prevention programs within their community. The statistical data about falls reveals that 1 in 4 Americans over the age of 65 fall each year. 1 in 5 falls cause serious injury such as bone fractures and head trauma. 95% of the bone fractures sustained during a fall are hip fractures, and head traumas from falls are the most common cause of traumatic brain injuries. As an emergency room nurse, I have seen firsthand that falls are very common in the older adult population. In fact, according to the data, every 11 seconds, an older adult is seen in the emergency room due to a fall. And sadly, every 19 minutes, an older adult dies due to a fall. Falls in elderly patients are significant to the nursing profession because they are the leading cause of fatal injury and the most common cause of non-fatal traumatic-related hospitalizations. 3 million older adults are treated in emergency departments annually. 800,000 of those require hospitalization. Of those 800,000, 300,000 are admitted for hip fractures, and 27,000 older adults will die due to injuries sustained as a result of a fall. According to the CDC, the total cost of fall-related injuries in 2015 equaled $50 billion, and Medicare and Medicaid shouldered 75% of that cost. This is a case study of a 74-year-old Caucasian female who presents to the office with a chief complaint of a recent fall. She is accompanied by her daughter, who is concerned for her mother's safety. The patient reports feeling unsteady on her feet the majority of time and recently started using a cane to assist her balance. She states she fell yesterday when she was trying to straighten the corner of a throw rug in her living room, denies loss of consciousness or injury, and states she fell forward into the seat of her recliner. Her daughter is afraid she will fall again and break her hip. The next few slides contain information gathered about the patient's past medical and surgical history, allergies, current medications, immunizations, social history, and health maintenance history. Feel free to pause and review the information in its entirety. However, I will point out pertinent positives obtained from the patient, which are highlighted in red. She has a history of rheumatoid arthritis with long-term steroid use. As we know, long-term steroid use can weaken the bones, making them more porous and subject to fractures. Consequently, she has osteoporosis, as evidenced by a T-score of negative 2.5 on the DEXA scan. Additionally, it's important to note that she experienced early surgical menopause due to a total hysterectomy. There is a direct relationship between lack of estrogen and rapid bone resorption and breakdown. It also should be noted that she smokes a half pack of cigarettes per week. While these particular factors aren't directly predictive of a fall, they do increase the risk of serious injury and fractures. The patient is still living independently at home and conducting her ADLs and IADLs without assistance. However, the patient reports that she has been feeling unsteady on her feet, and her daughter states that she has noticed that the patient's home isn't as clean as it typically is. In response, the patient stated while she is still able to complete housekeeping tasks, she is not able to move as quickly as she once did. Additional information obtained during the review of systems includes pertinent positives of blurry vision and occasional stress incontinence, both of which are factors that increase the patient's risk of falling. Pertinent negatives I want to point out include the absence of fever, cardiovascular and pulmonary symptoms, and urinary urgency and frequency. In continuation of the review of systems, more pertinent positives I want to point out include chronic joint pain, history of a fall, unsteadiness, and recent addition of an assistive device. Additional pertinent negatives include lack of endocrine systems, which could indicate thyroid conditions, lack of muscle weakness or foot problems, no cognitive changes or neurological symptoms like dizziness, numbness, or weakness were reported. Based on the review of systems, I included the general survey, integumentary, HEENT, cardiovascular and pulmonary systems, musculoskeletal, and neurological systems in my physical assessment. The general assessment revealed the patient was alert and oriented and appropriate. The skin assessment revealed an area of ecchymosis to the posterior lateral aspect of the right thigh, likely sustained during her fall yesterday. The HEENT exam revealed the presence of cataracts bilaterally, which poses a risk for falls. It is important to assess the cardiovascular and pulmonary systems to rule out any conditions that may have contributed to the patient's previous fall or that may be predictive of a future fall, such as abnormal rate or rhythm, poor circulation, or adventitious breath sounds. The musculoskeletal and neurological systems should also be assessed to determine skeletal changes such as kyphosis, muscle tone and strength, the presence of cognitive decline, delayed reflexes, vertigo, paresthesias, and cranial nerve function. Diagnostics that should be conducted include a CBC, CMP, UA, vitamin D and B12 levels, thyroid studies, and a repeat DEXA scan to determine if the patient's T-score has worsened, indicating a higher risk of falls. Please review the screenings that were completed to determine the patient's fall risk. I will highlight the abnormals. The patient scored a 6 on the Stay Independent brochure, indicating she was at risk for falls. The patient scored a 13.5 on the timed Get Up and Go test, which indicates a fall risk. She was unsuccessful in the 4-stage balance test, and the fracture assessment tool revealed her 10-year probability of fracture was 30%, with a 17% risk of hip fracture. Differential diagnoses for falls or risk of falls depends on the causes. Possible causes include visual impairment, vertigo, arthritis, dementia, depression or delirium, CVA or TIA, orthostatic hypotension, syncope, abnormal muscle tone or function, polypharmacy or medication side effects, substance use, and environmental hazards. I do want to note that the patient's medications were reviewed, as well as her blood pressure log from home. Her blood pressure is stable on her current doses of low pressor and HCTZ, and she did not exhibit any orthostatic changes upon examination. Remember to always assess medications for additive effects, interactions, and side effects that may contribute to a fall. My final diagnoses for this patient are multifactorial and include rheumatoid arthritis on long-term corticosteroids, early surgical menopause, tobacco use, bilateral cataracts, stress incontinence, and environmental factors. This patient was encouraged to increase her caloric intake and physical activity. She was referred to physical therapy for strengthening and an ophthalmologist for evaluation of cataracts. The home safety assessment was conducted, and she and the family were instructed to make modifications to prevent the risk of falling. For instance, removing throw rugs and ensuring adequate lighting will help reduce her risk of falls. The patient was highly encouraged to discontinue tobacco use and to begin vitamin D and calcium supplementation. The medication, alendronate, or Fosamax, is appropriate for this patient based on her history, T-score, and fracture risk assessment. Fosamax can be taken once weekly. However, a daily dose of 10 milligrams by mouth is recommended for glucocorticoid-induced osteoporosis in postmenopausal women who are not on hormone replacement therapy. Community resources in Johnson City, Tennessee include Stepping on Falls Prevention at the Memorial Park Community Center, and the Johnson City Senior Center offers Tai Chi for arthritis and fall prevention, as well as Silver Sneakers, both of which are great programs to enhance physical activity in the older adult. Maintaining an active lifestyle, smoking cessation, making proper home modifications, and attending fall prevention programs are all positive health behaviors that can greatly reduce the older adult's risk of falls. Living alone can certainly have a negative effect on an at-risk patient, but having strong social support from friends and family, staying active in church, and volunteering in the community can have positive effects on the older adult patient. We must remember that financial aspects related to health care, insurance, and income are all issues that the older adult is fully aware of and can affect the way in which they are able to care for themselves. Legal and ethical issues related to falls include not having an adequate standard for fall prevention. Each case is individualized and should be treated as such, and allowing the older adult the preservation of autonomous decision-making for as long as possible. Research has proven that Tai Chi and seated exercise classes can help strengthen the older adult and reduce the risk of falling and hip fractures. Research also shows us that older adults who fall are also more likely to cause car crashes. Keep that in mind when addressing fall risks among patients, as falls are usually indicative of other health conditions. Postmenopausal women absolutely require adequate calcium and vitamin D supplementation, and vitamin D therapy has proven to be effective in improving muscle strength and balance. Research also proves that cigarette smoking accelerates bone loss. And finally, repeating DEXA scans are recommended after initiation of therapy to determine the resulting effectiveness. To wrap up this presentation, let's review some key takeaways. Recall that falls are the leading cause of injury in older adults, and that falls are not a normal part of aging. It's important to familiarize yourself with the risk factors and to keep in mind that those risks are often multifactorial and are often indicative of other underlying health conditions. Because falls are so common among our older adult patients, assess for falls at each primary care visit, as well as assess the patient's gait, mobility, and ask about any safety concerns at home. In addition, always assess the patient's medications for side effects, interactions, and additive effects that may contribute to a fall. We need to educate our older patients that the risk of falling can be reduced with lifestyle modifications, including physical activity, proper nutrition, and taking care of preventative visits such as vision screening. Become familiar with the fall prevention programs available in your community and encourage your older adult patients to become active participants, which will enhance both physical and social well-being. This concludes this presentation on the geriatric syndrome falls. Thank you for your attention.